Welcome back to Behind the Counter, Pharmacy and Beyond, the podcast where real stories meet real business lessons. I'm your host, Solomon Abuwede. In the last episode, I spoke to Toyido Litlam, the founder of the Pharmacist Cooperative, and we explored his journey from being an advocate for locums to being an innovator in the pharmacy space. If you've missed it, go back and catch up, especially if you're a contractor, because it's packed with actionable insights and it was an eye-opener for me. But today, we're diving into something personal, something powerful. Bushra Effendi joins me and we're discussing women's health and how Bushra is revolutionizing the menopause conversation across the NHS, private practice and pharmacy training. She's bold, brilliant and breaking barriers. Welcome to the show, Bushra.
Thank you for having me, Solomon.
All right, Bushra, before we get started, we'll loosen up a little bit. You've told me about your love for R&B music and his music. So what's your favorite R&B music from the 90s?
Oh, wow. There's loads. It was the best era for R&B.
The Gen Zs might disagree with that, but okay.
Okay, so it'd have to be 112,
Okay.
Jagged Edge,
Okay.
Keith Sweat, Twist.
Okay. So you really were into your R&B music in the 90s then?
Yeah, a bit of Missy Elliott, Mario, Usher. I think we were the best generation, I think, in terms of music. We got the best.
You know, I can't disagree with that. But like I said, the Gen Zs may have something different to say. Let's sort of take it back a bit, Bushra. What was the first time what first pulled you into women's health?
Well, to be quite honest, Solomon, it's probably been going on for quite some time. I think I'm kind of just drawn to stuff that makes, people feel unseen or misunderstood. And menopause is one of those areas, I guess, in terms of work that I've done privately. So I do a little bit of aesthetics, and it was these women that were on my couch. And I was like, there's got to be something else going on here in terms of there seems to be a pattern here in terms of these women, and they're seeing the same thing. They're saying the same thing of they're being unseen, misunderstood, heard, especially if they're going to see kind of clinicians in the GP practice. And that's what it was. And they were being told, oh, actually, it's just part of getting old. And I was like, there's got to be something bigger than that. And I was like, right, I'm going to dig a little bit deep and see what's going on.
Okay. And so what was the moment for you early in your career where you thought, this is my calling, this is something I want to do?
I think it was probably, I was in a consultation actually when I was working in practice, and I was looking, and there was this patient who kept coming back. And there was multiple times actually she came back, and she was only in her early 50s. And I was thinking, well, there's seriously got to be something wrong here. And as I kind of trawled through the notes, there was stuff that was coming through in her early 30s. And I was like, and there was nothing. She'd been for a number of tests, had everything tested, and everything was coming back clear. And I was like, let's see what else is going on. And then I kind of started doing a little bit of research to say, actually, what happens in change, what changes are happening. And that's probably what was the trigger point for me. And as I kind of delved a little bit deeper, I could see that actually this whole array of symptoms that she'd been coming in with could possibly have been linked to changes in the hormones. And so that was probably the turning point for me to say, actually, we've got to look a little bit closer to what's going on with hormones in women.
Okay, well, fantastic. And so you went from Pharmacist to being a national voice on menopause. And if you could just take the listeners back, what did that path look like for you? Obviously, coming out of uni, fresh pharmacist, what did you do early in your career? What's your path to where you are now?
Oh, that's long. Strap yourselves in. You're in for a roller coaster ride with this one. In terms of, I came out of university 2005, and I think like most of us did, we went straight into community because it was great. And the pay was good at that point in time as well, I'd say. So off I proctored and I did community pharmacy work, and quite quickly you went into managerial positions. I don't know if you recall, and they were kind of really promoting you. So I did that for quite a long time. I worked for multiples. I then managed satellite branches as well. So I worked for a big multiple, managed satellite branches, and up and had my children, and then still carried on with that, and then realized that actually didn't want to be in a practice where I was going to be working 10, 11-hour shifts, and then moved to an independent contractor, which was great because actually it gave me the autonomy. I didn't find that there was red tape. And then I was like, I want to make a difference, to be quite honest. Yes, I'm dealing with the prescriptions here, but actually I want to know what's going on the other side. So I then said, well, let me see what's going on. And I thought, do I want to go into primary care? And I thought, no, let me go back and see what's going on with the other pharmacies first. So I got a role with the LPC. So that was looking after nearly 600 pharmacies across West Yorkshire, which was great, which was when the new contract started to come in. place, and it was supporting those pharmacists to kind of implement services. So I did that for about 18 months, and I was like, right, now I need to get myself into primary care. I think I'm in a position. So off I trotted and did my LPC work and did primary care alongside it. Did that for a bit and then thought, actually, I want to be in a position where I can make some changes or kind of influence changes. So then I went up to work for what used to be called the CCGs and is now ICB. And we don't know what they will be in the future because there's lots of change happening. And I did that. But during that time when I was in primary care and at the LPC, I started to train in aesthetics. So in my time when I was in primary care and the LPC, I did my training in aesthetics. So this was, mid 2010, so probably 2017 is when I started to do that. And then I started to see actually what's going on in women's health. And then I was already in the ICB at that point. I thought, let me see what's going on in terms of policy changes and kind of guidelines. And they were all out of date. And so off I trotted again to my line manager and I said, actually, I'd like to do women's health. And before I could get to the end of my sentence or say anything else, and they went, it's all yours, Bushra, because nobody else wants to touch women's health. And I guess the problem that we've got is there's no money in women's health, because on the outside it is seen as just a hormonal thing. But we've got to understand that actually women's health kind of is deep rooted in all the other healthcare areas as well. So we know that how it impacts cardiovascular health, how it impacts bone health, how it can have an impact in terms of psychological health, but just general well-being as well. There's the mental impact, the psychological impact. There's a psychological impact, but also the physical impact that the menopause brings as well. So yeah, so that's where I am today. So I did a little bit of that work. Then off I went and did some charity work. So I started working with the menopause charity as a clinical advisor, then started working with CPP and contributed to their menopause module that they did. Then did some work kind of working with community pharmacy and doing some bits around contraception. Then I've joined the Faculty of Sexual and Reproductive Health as their pharmacist representative for their courses and CPD committee. I've then worked with pharma, and I guess one of the other things is that pharma seen as the big bad wolf, but they do a lot of research and it's really important that you work with them. So through my private practice, I then worked with pharma to do educational stuff because I realized that there was a gap in the educational side of it. So I've worked with pharma. And then from there, I did all my BMS training. I did the International Menopause Society training, and then realized that I'd plowed thousands of pounds into this independently. And then I started to work with Allied Health Training, who deliver training. And they said, well, Bushra, would you mind, would you be interested in doing some menopause training? They didn't need to get to the end of the sentence. And I was like, yes, I didn't actually ask what it entailed, what it was going to cost me in terms of time and effort. And I was like, yes, I'm there. And I guess that's my problem. I say yes to everything without thinking what it's going to, or how it's going to impact me. And so now I deliver training through Allied Health Training. I've done work with some other organizations as well in terms of delivering educational meetings as well. Worked within kind of still doing my work in the ICB, helped to set up a pharmacist-led menopause service as well to improve access for patients, because although I do have a private clinic, I need to make sure that the system's fair as well. So anything that I kind of learn in my private practice, I tend to bring it back into the NHS as well.
That's fantastic, Bushra. You've obviously got a very, very sort of well-decorated CV, if you like, and you have been busy. But something I picked up from your introduction there, there's no money in women's health. Do you think the NHS is missing a trick, or the government are missing a trick?
Yeah. I think I think women's health is seen as a bit of a niche market, and I don't think the wider picture is seen often. And my concern always is, why do we keep doing the same things all the time? Because clearly it's not working. So cardiovascular health always gets, a big pot of money thrown at it, as does diabetes. And rightly so, because actually they are key clinical areas that we need to impact on. But actually we need to make sure that we're looking after our women's as well, because when those hormones change, it has a detrimental impact in lots of different clinical areas, and it can have long-term effects as well. And I think women's health is more preventative if we capture it early than it is reactive. And I think a lot of the NHS can sometimes be reactive. So yeah, I'm hoping that somebody will at some point pick up and say, actually, do you know what, Bushra, maybe we'll give it a different shot.
It's a great thing you're doing, Bushra, and I think it reminded me of some of the other sort of areas that have not been very popular, and we've got to start from somewhere, and somebody's sort of got to fight the battle, and I think it's a great thing that you're doing. Do you remember the first patient that you helped, and what was the impact, and then what changed for that patient?
I would say Oh, there's been quite a few actually. I think one that really sticks out is she came to see me and I was like, she said, "Oh, nobody's really listening to me." And I was like, "Oh, well, let me have a look and see what's going on with the hormones." And we went on this journey and it was about 6 months. And she came back after she'd kind of been on this journey with me at 6 months. And she said, "Do you know what, Bushra? Had I seen you 12 months earlier, I'd still be married."
Wow.
And I was like, "Oh my gosh, I wasn't expecting that."
Yeah.
Because she said she's because there's a whole host of symptoms that go with it, and I know we're talking predominantly menopause here, but there's loads, about 48 different symptoms, Solomon, that nobody knows about, and they come in these waves. So you get a flurry of symptoms, and they settle, and then you get another flurry of symptoms, and you don't know whether you're coming or going. And rage and the kind of psychological changes that happen are huge, and it has an impact both on your kind of your professional life, your personal life. You feel as if you become a shadow of who you are. And a lot of times these patients come in and they say, actually, I don't even recognize myself.
Do you think there's I don't know if stigma is the word here, but do you think there's something in society where perhaps we joke about it a lot and people will talk about it and say, oh, you must be menopausal or it's menopause. And when your wife gets to that age, well, you're not going to do this and it's a different person. So do you think there's a stigma attached to perimenopausal women?
Yeah. Yeah, I think there is. But I think we're making strides in changing that, to be quite honest. I think we're really lucky. We've got some real great advocates out there that are kind of talking about women's health. And actually, it's filtered down to grassroots levels as well in terms of being able to talk about it. I think we have to understand that within certain parts of society, a woman's worth is still based on her ability to have children, so her fertility. And so the minute you kind of banter around the word of menopause or kind of perimenopause, they think, well, actually, that's it. Your worth has kind of dropped off the edge of a cliff. But I think we're having a kind of, but there's been a shift that's come in. But yeah, there is still a real stigma attached to it. And certain parts of society still see it as a bit of a taboo and they don't talk about it.
Right. Okay. And do you think that is that a big thing that you've seen? So do you get women come to your clinic and they just can't speak to anybody else?
Yeah. So in terms of who I see in my clinic, there's a particular type of cohort of patients that I see. And so off the back of that, I trotted again, actually, Solomon, to do something else. So I work as part of a menopause cafe in an inner city area of Leeds. So the Shine Centre in Leeds is brilliant. They've put on this menopause cafe and I've started kind of going as their clinician. And we started off initially with just a couple of women and I'd like to think it's exploded. We've now got about 20, 30 women that turn up once a month and they come and they just use it as a way to kind of decompress and talk about what their symptoms are. And the women that I see in that cafe are totally different to the people that I see in my clinic. And it's great because what they're doing is they're taking those nuggets of information from that cafe and filtering it through their kind of the communities. And I'll be honest, and I think I'll be quite frank to say we women talk and we're on every WhatsApp group going. So actually we put a message on there and it's like spreads like wildfire. So it's great.
You're busy. I mean, put your fingers in every pie. We've just sort of touched on women's health alone, but you do some stuff around dermatology and antimicrobials. What's a week in the life of Bushra like?
Oh gosh. In my 10 days in the week, uh, it's quite a bit
Sounds
actually.
like it.
Yeah, so 3 days a week I'm in the NHS. 1 day a week I work for I consult for a menopause clinic, and then the other 3 days I fill out in doing pharma work, my own clinic work, and my training, and then trying to be a mom as well.
I was going to say, you haven't mentioned that. That's why you feel that on the other 3 days after the seven.
But I must say, I do kind of my time when it gets to 5 o'clock, I've clocked off. That time is for the children, to be quite honest. It is family time. But then I'm a night owl. So once kind of I've done my mummy duties, I then get back onto kind of doing things around women's health. But I'm a night owl and an early riser. So that's probably where I find the time.
No sleep for you then. Not much. So, in terms of the gaps that we've got, what are the gaps that you see in menopause care today, right from diagnosis to treatment? So, we've said the government or the NHS, there isn't money. Are they letting down women? Is that they're missing a tree? But what are the gaps that you sort of see from diagnosis to treatment?
I think the gaps probably are around education with clinicians. I think that is a huge gap. And I think part of that is because of how we're trained as well as pharmacists. We didn't get might have got one module. I know when I've spoken to GPs as well, they said actually we do our menopause training when we're on our obs and gynae rotation. And actually when they're on their obs and gynae rotation, how many menopausal patients are they going to see? Not many, I would
Right.
assume. And so that's probably where the gap is. I think we still have a misunderstanding around kind of hormonal health and the risks that come with it. So that again is alluding to the fact that there's an educational need. But I also think in terms of getting the information out there to communities that might not kind of be forthcoming in kind of accessing care in those areas. I think that's one of the other pieces of work. So that outreach work is really important as well. So I think those are kind of where we should really focus. I think in terms of where we are, we can see the data, can't we, in terms of who's accessing HRT, who's kind of accessing that care from clinicians around menopause. So the data gives us kind of what the problem is. And then what we need to do is make sure that we're including everybody in that conversation. And that's part of the solution, isn't it? So
Yeah, I mean, there is the HRT exemption certificate, which has come in recent years, and I'm guessing that's something that you welcome massively with open arms.
absolutely. I think it was just brilliant in terms of what they've done. I think there's been more people that have come through to access HRT because, we have to understand that there is a socioeconomical barrier to accessing HRT historically because of the cost implications. If you're on two hormones, which you probably are going to be on, you know, that's a lot of money that you're going to be spending. And if it's only on HRT, you're only getting 2 items a month, then actually you're not really going to be qualifying for a normal prepayment certificate. So, in terms of having the HRT certificate, it was brilliant.
And obviously, in your journey so far, you would have fought a lot of battles and put out a lot of fires. And can you tell our listeners a moment where you sort of challenged the norm, and how you've helped a colleague or a patient differently?
So I think the challenge has to be in terms of when I felt as if I've had to speak to another clinician in terms of the work they'd done. So I saw a patient who had gone through the menopause in their mid 40s, was told that they shouldn't go on HRT because it would give them breast cancer. And they then turned up back in my care 10 years later, riddled with osteoporosis because they didn't get the HRT that they needed. And so that was probably a challenge because I did go back and said, "Oh, actually, do you know what? Can I just highlight to you that this is now a concern? And had we given her the HRT in her mid 40s, we probably wouldn't be here." And that was a difficult conversation to have because actually, as pharmacists, historically, we're quite scared of accessing kind of raising concerns with GPs. But I think that was probably the challenge. And coming with the knowledge that I had, I think it made it a little bit easier. But we were able to kind of, off the back of that, I was able to have a really in-depth conversation with the clinician. And we were able to kind of talk through kind of what the risks and benefits were, where their kind of educational gaps were, being able to share some tools that they could put in the toolbox to share with them in terms of future practice. So yeah, I guess that was probably the challenging bit. Not only was it challenging in terms of how I was dealing with the patient because that was awful, but also in terms of how I was going to upskill this clinician.
No. You mentioned osteoporosis there, and that was actually my dissertation at university. The effect of hormones on the drugs on osteoporosis and the link between both of them. That's just taking me back a few years, only a couple of years ago. But just made me remember that. Let's talk pharmacy specifically now, because majority of our listeners are either pharmacy owners or people looking to sort of start their own pharmacy. You're delivering CPP training and mentoring, other clinicians. What's the one thing that as pharmacy professionals we need to unlearn about menopause?
I think we need to unlearn the fact that it's risky by default. HRT is risky by default. And that's the thing, isn't it? Because we had the study in the early 2000s, which obviously really scared a lot of the clinicians. And now we've got to undo all that learning that we did. I think that would probably be the bit that we need to have. And also the fact that menopause isn't a one size fits all. So I know when I kind of deliver my training, I see lots of clinicians coming in thinking they're going to walk out with the answers. And actually, they probably walk out feeling everything's even more grey than it was when they turned up, to be quite honest. But we give them the tools in terms of being able to know where they can find this. And I think that's the thing, isn't it? The person that's sat in front of you is an individual and everyone has a different journey that they're on. So I think the unlearning has to come in terms of risks surrounding HRT, and that HRT is risky by default. I think we've got to unlearn that. And then we also need to unlearn the fact that actually there's got to be a set criteria. And I think as pharmacists, we're so kind of regimented in terms of, we have to square pegs go into square, holes. And we have to think, we have to start changing the way we think a little bit which can be quite challenging because we are really quite regimented in the way we work. We're quite risk averse as well in terms of what we do. And so it feels a little bit as if we're out of our comfort zone. But I do know that when I've spoken to clinicians that have gone back and taken that menopause care into their clinics, they've come back and said, oh, actually, do you know what? It's made a huge difference. I feel as if I'm doing something worthwhile, and they can see it.
And if you've got pharmacy team or pharmacy owner listening who wants to sort of get into menopausal care, private service, for example, how can they start small to build a meaningful service?
So I think the first thing would be, and I say this at the training actually, open the boxes of the HRT, get the reps in and use the products. I would say probably all of about 7 to 8 years ago when I wasn't actually in women's health and I'd been dishing out Everell Conti, I actually didn't know what the patches looked like in the box. I mean, how many of us have opened a box and said, actually, which patch is which? And I guess that comes from one of my patients, and she ran and she was fuming. And like you do, you start panicking, thinking, oh my gosh, what's gone in here? She says, I'm really not feeling very well. And you've put me on these patches and they're not working. Hey, let me see what's going on here. I said, well, what are you doing? How are you using the patches? Well, I'm taking one out and using it every day, like every few days, like you've told me, changing it twice a week. And I was like, okay, so I said, you do know that there's 2 different patches. And she went, you never told me that. And I was like, oh my gosh, I'm sure I told you that. But that's the other thing, isn't it? In terms of you go in, you don't know what's in the box as well. So she was using it very much like going in, it's like pick and make, putting a hand in and taking out what she wanted for the day and using it. So I think one of the things would be to start familiarizing yourself with HRT. You can do that by actually probably linking into the pharma companies and getting some placebos from them and getting your hand on what they feel like as well on the skin. I would also say in terms of when you're handing out a HRT prescription, because having the conversation is so scary when you first got, it's like when you first qualify as a pharmacist. I mean, how many times have you done that, handed that bag over, put it back, opened it up, take the products out, looked at the box, put it back in, handed it out, put it back again. And actually it's the same thing with HRT. So what I would say is when you're handing out your HRT prescriptions, just say to them, oh, do you mind if I have a quick word? How are you getting on? And it will kind of start normalizing that conversation that you're having with your patients, because it's quite scary on how to approach it as well.
You talk a lot about inclusive, data-driven hormonal care. What does that look like in practice?
Well, yeah, the data says that actually there's a particular cohort of individuals that will access HRT. And that's because they've got access to social media. And we have to understand that within certain parts of the community, there might be time poverty. So they haven't got the time to listen to these podcasts and or listen to things that are on the television. We've also got tech poverty as well. So those are kind of the things. But in terms of those cohorts of patients that are in front of me who might not be actually accessing HRT, they might be coming in to buy things for kind of really dry skin, because that's one of the other symptoms. They might be coming in to buy things for incontinence, because that's another symptom, which is huge within kind of the population. I would say probably approach the conversation to say, oh, I can see that you're buying this. Is there anything else? Do you want to talk about it? And actually get them into the consultation room and have that conversation with them, normalize the conversation with them around kind of HRT, around menopause change, care, how hormones change, the impact that it can have on lots of different areas. I think that's probably the way forward with that.
I've been a pharmacist for many years, Bushra, as you know, and I've got to admit, I'm hearing you speak now, and you're mentioning things that are symptoms of being perimenopausal. And I had absolutely no idea, if I'm being honest. Dry skin, you've just mentioned that very casually. You spoke to me earlier, and I think off recording, that whistling in the ears is one. You've just talked about incontinence being another one. And that is really mind blowing for me and very, very eye opening. Just for the listeners, are there any other symptoms that are common symptoms that maybe we wouldn't link to being perimenopausal that you could just share?
Okay. And so in terms of, I'll start from the top and work my way down. So hair loss, that's another one. Dry eyes, receding gums, that's a huge one. So women will say, actually, I feel as if my gums are kind of moving and my teeth are moving and they're changing shape. Palpitations is another one. They will say they find that the skin's crawling, the anxiety, the rage. That's a huge one, to be quite honest. A patient come in and she said, oh, and I really wanted to come and speak to you because I've got loads of these symptoms going on. And she said, I think the telltale sign is my child said to me, Mummy, you're like a Ferrari. And she said, I thought I was being really sleek and thought I was amazing. Actually, he went, no, you Mummy, you go from 0 to 60 so fast. It's faster than a Ferrari, to be quite honest. So these are the kind of things that are kind of occurring. I think I talked about the incontinence, but actually the genital urinary symptoms of the menopause are huge. And I know I've spoken about kind of some of the other symptoms, but they come in waves. So you get a flurry of symptoms, they settle, and then you get another flurry of symptoms and they settle. The genital urinary symptoms, so that's recurrent UTIs. And we know that we're dealing with UTIs as part of the Pharmacy First service in community pharmacies at the moment. Recurrent bouts of thrush, the urinary urgency, the stress incontinence that we get. These are all issues that just get progressively worse if we don't treat them right. So, like I said, some of those other symptoms come and go. The genital urinary symptoms of the menopause, which we often don't talk about because they're quite embarrassing as well, are the only ones that we really need to treat, and because they will get worse. And I've had, in fact, from that menopause cafe that I run, had somebody come in and she said, "Oh my gosh, my mum keeps getting really bad UTIs. I'm going to go back and speak to the GP about how we could possibly use vaginal estrogen." And I know you've now got Gina over the counter. You've also got a Vest, which is another product, which is for postmenopausal women that you can sell in community pharmacies. So there's lots of change happening as well in community pharmacy that you can kind of offer care to your patients as well.
Thank you so much for that, Bushra. I'm sure just our listeners will find it just as insightful as I have with all of those things. So let's zoom out a little bit and sort of go back to Bushra, the person. So you describe yourself to me as a mom, a foodie, you say,
Yeah, Jodie.
a lover of comedy. And how do those pieces of you sort of shape the way you show up to work every day for your patients and for your colleagues? How does that shape you as an individual?
So in terms of, I think comedy's probably got to be my first love. I think my husband and my children probably come secondary to comedy, to be quite honest. But I think that's the thing. I think because it can be so traumatic, can the menopause for some patients. And actually, when you're having these consultations with patients, they're offloading a lot of stuff to you. So I guess in terms of, I don't kind of trivialize what the symptoms that they're coming with, but kind of just even like that, she was saying, it's like a Ferrari, that kind. So I try to kind of make the conversation a little bit easier. I talk a lot about myself and my own symptoms, and I'll be open and honest here with you, Solomon. I am, in my mid 40s, going through the perimenopause, trying to juggle a career, trying to kind of raise, I've now got a house of 2 teenagers, which is, you try living in a house, perimenopause and 2 teenagers home as well. Tell you what, that's preparing me for anything, isn't it, really? And then, so I guess I bring humor into a lot of my stuff. I'm very similar to kind of what I'm doing now, to be quite, it's lighten the load a little bit. And then in terms of food, I kind of bring what I've done myself in terms of nutritional stuff, in terms of making sure how I fixed my eating. So I put on a huge amount of weight kind of as I transitioned into the perimenopause. And so I had to redo how I was eating. And I passed that on to my patients. I'm not a nutritionist. And so I'm not kind of advocating for it, but I share my own kind of tips and tricks that I've worked. So, making sure we're increasing protein. And that's actually a given, isn't it? Everybody knows that protein is great. Rechanging how I eat. So making sure that I have my fiber or my salad first. So my veg and my salad comes before I eat my protein. And then I have my carbohydrates at the end of my meal. So these are the kind of things that I incorporate into my consultation. And then I guess the music, I guess that probably is the moving, isn't it? So yeah, dancing around the kitchen whilst I'm prepping dinner is great because I've got, a hip hop and R&B going on in the background. Yeah. So that's the other thing, moving regularly, getting that 150 minutes of exercise over the period of a week. But actually, it doesn't have to be pounding the streets like you might have done historically. Just a brisk walk, getting your kind of heart rate up, feeling a little bit out of breath, just those simple things. Even things like, I am a big foodie. I'm a big foodie. I've started to like lots of cake and cookies. I now have a skipping rope in my kitchen. I do 50 skips if I'm going to put my hand in a cookie jar.
50 skips if you put your hands in a cookie jar.
Yeah.
I'm not going to introduce that one at home.
So yeah, so that's it. So it's just little things like that, tips and tricks, isn't it? So I kind of, the music bit is kind of the moving around kind of, and that's great. And it's great for lifting your mood.
So what's been the hardest part of balancing NHS work, private work, motherhood, and self-care, I suppose, for yourself as well? What's been the hardest part of balancing all of those things for you?
So it's a real balancing act, to be quite honest. And I guess the NHS gives me system insight. And then my private clinic gives me delivery of, allows me to deliver personalized care. So I guess that's what it is. And I guess I stay rooted in evidence using both platforms to advocate for change, to be quite honest. So, but it's a real balancing act. And I think, I'll be honest, in terms of when I kind of transitioned into women's health, and I think I mentioned this to you before, didn't I, Solomon? I had a lot of FOMO going on. So at the time I was raising my family, I was kind of sorting my house out, I was having a house built, and I was looking at people around me and they were kind of branching out into clinical areas, and they were doing their prescribing course. I hadn't even done my prescribing course in 2015, to be quite honest. And I had FOMO going on. So I guess what I needed to do, and I would say to anybody that's kind of listening to this podcast, is things happen at the right time. So don't kind of force things, to be quite honest, because I know I say I do a lot of stuff, but I do get overwhelmed, Solomon. I feel as if I am juggling, and there's certain days when I don't feel as if I'm balancing things. So, but I think that comes from looking at others and saying, actually, you want to be doing what they're doing as well. But it doesn't, everything works out in the end, I would say. So just take it in small baby steps. I feel as if I kind of started to run before I could walk, and I was saying yes to everything. And I think now, looking back at what I did, I wish I'd balanced it a little bit better and probably said no and realized that I was on a different journey to what others are. And I guess there's going to be clinicians on this that are listening to your podcast thinking, oh gosh, actually, do you know what? I want to be there, or I want to do that, or I want to do, they might have an interest in, something, another clinical area. They might want to look at mental health, or they might want to look at diabetes, or they might want to look at bone health and specialize in any of those areas. I would say take small steps. Don't overdo it, because you will be overwhelmed, and do it really well. I feel as if I was juggling. My children were a lot younger at the time, and I don't know if I think I balanced it all that well initially.
It's that old cliche saying, isn't it? Hindsight's a beautiful thing. And I think what's really interesting listening to you there, and I think would be really important for a lot of our listeners, is you're saying, don't overdo it, you will be overwhelmed. And that's the human nature, the human behind everything you do. And I think in this day and age, everything's sort of fast paced, moving so quickly. And we see a lot on social media, and we try to be what everybody else is. And we try to sort of put ourselves under a lot of pressure. So I think it's really important that you're saying that. And that's something that I do share, and I agree 100%. You know me very well as well, Bushra, and there is a lot of pressure. That it's just probably just the way we're built, but you do need time for that self-care and time to sort of realize where your limits are. And I suppose, like you said, there is a time for everything, and it will come. And when it's your time, you know. And sometimes when you try things, I suppose, and you fail, or you fail in court, or don't achieve what you set out to do the first time. And it's very important to know that Rome was not built in a day, as they say. We just got to keep going at it.
Yeah. And I love that point that you've made there, Solomon, because we sometimes think, actually, now that I've started this and I've spent 6 months or I've spent 12 months doing this, I've got to keep battling it because I spent so much time in it. But sometimes things actually don't work out for you. I mean, I did loads of stuff in terms beforehand. So I did respiratory and I did AF. And I could have thought, well, actually, I've been doing it for 12 to 18 months in each of those areas. And now I've really got to persevere with it. Had I persevered with it, would I be where I am today? Probably not, actually.
Mhm.
And your social media post is brilliant. So I posted something actually the other day on about something that I work for the Menopause charity. I posted a video, and somebody said, oh, that's a lovely video. And I was like, great. But you didn't see the fact that actually I missed my train. I didn't know where I was. I'd gone to London. Obviously, I'm a northern girl. Going to London is like, wow, going to a different country, to be quite honest. I missed my train. I didn't know where the studio was, so I lost that. I thought I was going to be really fancy and wear heels, and I'm always in runners, to be quite honest. I kept my trousers, ripped the hem. My hair was, I was having a hot flush, and my hair was thinning, and so it was stuck to my scalp. So actually, yeah, if I did that as a caption, I think it'd be very different. It'd cause a lot of patients that I'd be reading it to me.
That probably leads me perfectly into my next question. Then, what's the one myth in women's health that needs to go? Just the one thing, the myth in women's health that needs to go.
So you're asking about what is the biggest myth. I would say that suffering is normal, and we've normalized the distress that women have to go through for so long. And so I think that's probably what it is. And I guess it's the same with lots of other clinical areas for women's health. So even things like periods, we say, actually, we assume, and the myth is there, that periods are painful. Well, actually, no, they shouldn't be painful. And so those are the kind of thing. I think the other thing is actually it's just part of aging. You need to just you'll get through it. And it's not, there is help out there. We're much more equipped to deal with these. So I would be saying to you, as a clinician, try and make every conversation count. If you feel that there's somebody that's coming in for those regular a different array of symptoms. So they might be coming in for muscular aches and pains 1 month. They might be coming in for incontinence pads the next. I mean, just be mindful that they who they're buying them for, you might want to have that conversation. But just keep an eye out of who's coming through the door, and you'll make the first conversation because it might be that they don't want to have the conversation with you. I would say in terms of, you might have contractors on this call actually, Solomon. So I would say, you know what? You've got Women's World Menopause Day. Why don't you put an event on? Why don't you call it Women's Week? And actually put on a Women's Week and actually create stuff, make it more available, get yourself into the consultation room to speak to these patients, have those conversations. And actually, we know that community pharmacists are the most accessible parts of healthcare, aren't they? They're actually open when other parts of the system are closed. So, we need to make sure that we're accessible to all these patients. So doing something like that might be great. And actually get your teams behind it as well, because, anecdotally, I would say that a large proportion of pharmacy teams are female.
Yeah.
And you've got gynecology, it's like a sitting duck, isn't it? You've got them there. You can equip them with being able to have those conversations. And I think community pharmacists have got an amazing skill set in terms of being able to prize things out of patients, get them to open up to you. I mean, we've all had it, haven't they? Popping the head round the door to say, my holiday was fab. How was yours? My son's getting married. My daughter's going on holiday. My daughter's passed a driving test. We know all that's going on with them, don't we, really? So, I think in terms of the relationships that you have with your patients, puts community pharmacists in a prime position to be able to have those conversations that they would have ordinarily thought were quite difficult to have.
That's it. If you're a pharmacy owner, pharmacy contractor listening to this, Bushra's challenge, the Women Week, put something out there. And at the end, Bushra is going to share details of how you can get in touch with her if you need any support with her. I'm sure Bushra will be more than happy to help. Bushra, just to pick up on something you said, that periods shouldn't be painful. I've got a lot of listeners, I'm sure, will be listening to this and thinking, what was she on about? And that may be both male and female listeners. So can you just expand a bit more on that? Why shouldn't periods be painful?
Well, actually, the whole process of you having a period should not be painful at all. If there is pain associated with it, there may be something else that's underlying. And we see a lot of women that kind of just put up, don't we, with this, because they say, oh, it's just part of the natural process. That's not the case. If there is patients that are coming in regularly, and I've seen it before, patients that are kind of saying, actually, I can't go to school. My daughter can't go to school because she's got really painful periods. They're writhing in pain. That's having an impact on their education, to be quite honest. But yeah, periods should not be painful. If they're painful, there might be something else going on. And I think we really need to have that conversation. We need to get the message out there as well. And I guess the other thing is schools are still teaching the same stuff in terms of PSHE that they were doing years ago. We're telling them how to not get pregnant, but actually we never talk to them about actually there's a finite time that you can get pregnant in. And I think there has to be a shift in terms of those educational stuff that we're doing. We're great in terms of the data that's coming out is showing that we're kind of having a bit of a plateau in terms of those teenage pregnancies. But actually the unwanted pregnancies in that 45 to 55 age bracket is starting to grow.
No, we obviously need to talk about this a lot more, not we as in you and I, but as a profession and as a country, and as a people, if you like. That it seems that there's a narrative that, when you're in a period, you should feel pain. And it almost seems like a lot of women are in a place of acceptance with it. It's that time of the month and they're getting really painful cramps and all of those things. But from what you're saying, it shouldn't be. And I think that's a key message that sort of should go out there to every listener here. Or if you know somebody, then know somebody, share this with them. So what should women do when they're feeling these pains then? So do they see the GP or what exactly is the advice?
Yeah. So one of the things that I would say is keep a bit of a diary of what's going on, what kind of symptoms you're getting, how frequently you're getting them. And actually the biggest note that you have to make is the impact in your quality of life. So how is it impacting your day-to-day routine? That has to be kind of documented. If you're saying, actually, do you know what? I might, it's stopping me from going to school. Well, actually, that's a huge impact. So you do need to probably book an appointment with your GP and see what's going on. You might want to, we now do contraception in community pharmacies as well. And actually, so the pharmacists that are delivering the contraception service are well trained, so they can kind of have those conversations. So you might want to not be talking about contraception, or you might not want to be talking about menopausal health, but actually you might be talking about period pain. So you're still talking about women's health to some degree. But yeah, so keeping a diary, keeping a log in terms of how it's impacting your quality of life, how it's impacting your day-to-day routine. And actually, if you feel that there's a pattern and you can see the pattern, then actually you probably need to see your GP about that. Or actually maybe a pharmacist in your GP practice.
Or a pharmacist in a community one day, maybe, about that.
Honestly, I really think that the shift is coming. I think there's a real shift that's coming, and I think there's going to be lots of things that community pharmacists can do. I think you're well placed. I think you have a completely brilliant set of skills that you do in terms of prizing information out of patients. I think we build really good relationships, long-term relationships, because you often see patients and you see the whole family, don't you? It's not just one person you're seeing. So you've built up a relationship with the whole family. So I think you're really well placed to have these sometimes quite complex conversations, really.
Thank you, Bushra. Now, I know you've got two boys, right? And you don't have any daughters, but let's pretend and just imagine you've got daughters for a split second. And if you could leave your daughters, or any listeners out there, if I've got two daughters, if you could leave your daughters with one message about health and their identity as a woman, what would that be?
Well, I come from a real girly household, Solomon. I'm one of five girls. We don't have any brothers. So me having the boys was a bit of an eye opener. And so in terms of, I would say, do not rely on anybody. I think that would be one of the things. So you are your own kind of, I always say you're going to live with yourself. That's the only person you live with for your whole life. So actually make sure that you give yourself time and make sure that you give yourself, nurture your body in terms of making sure that the nutrition is right, making sure that you don't allow negativity to kind of filter in, and don't worry about what people say. I think that's what those things that I would say. And actually, if you feel that there's something, and then in terms of healthcare, I would say if you feel that there's something not right with your body, seek that care because you know your body better than anybody else. And do not take no for an answer, I would say. Because that's the thing that I see in menopause care. They come in and they say, actually, I've been to see a clinician and they were saying, oh, they put me on antidepressants. That's the other thing we see, don't we? Women in their kind of, and you'll probably see it when you're kind of dispensing that, there's a huge spike. I mean, I haven't seen the data, but anecdotally, I would imagine there's a huge spike in antidepressant prescribing in the 40 to 50 age bracket in women.
Yeah. And I think, yeah, I think a lot of women as well I don't know if it's, I'm speaking for women here, I'm not a woman, but a lot of women I've sort of spoken to it either don't want it. I mean, I've spoken to a patient earlier on today, who was sort of talking about, I stopped taking my HRT medicines because I was getting a headache and I don't use it anymore. And I've been trying the herbal stuff. And I think that's sort of where it's, you talk about the new medicine service, right? HRT is not one of the medications in that list, but from what we've discussed today, it sounds to me like HRT should be on that list because certainly, like I said, I've spoken to at least one patient today and I've spoken to many over the years in my career who would stop taking the medication because of the headache and because of the side effects they get in. And I suppose having that conversation with a trained pharmacist a couple of times in the first 4 weeks of taking the medication might reassure you, and sort of get you to carry on taking it.
Absolutely. I mean, we see a lot in the social media, don't we, and in the press around HRT and that it's the magic cure. But actually, nobody tells you that you've got to take it for 3 to 6 months for you to really feel the benefits. And so you prescribe HRT to them and you get a call within a few days to say, this isn't working for me. It's not working and I'm not going to take the risk because you've done all the risk assessment and you've talked to them about the risks and the benefits of HRT. And all they can now think is actually, if I take HRT, I'm going to get breast cancer, I'm going to get a blood clot. And, that the brain fog hasn't settled within the first 3 days of taking it. Well, actually, that's when you really need to be having that support network in place for them to be calling them and kind of reassuring them. I also think in terms of that first 3 to 6 months, that's when most of that unscheduled bleeding occurs. And that's what stops them from continuing with their HRT regime as well. So we need to make sure that we, maybe we've taken a piece of work away from this, haven't we? In terms of, just in case I had a minute to sleep, Solomon. Thank you.
Well, I'll leave that one with you and you can start pushing the agenda when you're speaking to your decision makers. But I think
I have to do it in my sleep now, Solomon.
I do think generally there is a case for it. Like I said, I think, obviously antidepressants are coming on in October as part of the new medicine service within community pharmacy. And I think that's another huge one where that conversation needs to happen. But certainly, and I think the NHS is doing a lot and there is a lot of sort of movement, like you mentioned. And I think a big move was the HRT exemption, which obviously we discussed earlier on. And I think, it will happen. I think women's health is sort of taking more of a spotlight. And it's thanks to people like yourself. They're sort of working hard in the background and you just need to keep going and keep pushing at it. And I'm sure one day we'll get exactly what's required. Before we wrap up, Bushra, we started taking questions from our audience and listeners, something we started in the last episode. And these are real questions from our listeners. So I've got a few questions for you. The first one simply says, why did you decide? So this is from an aspiring pharmacy contractor. Okay. And this particular individual is looking to go into private services and set up a private clinic. And he's asking, why did you decide to set up your own private menopause clinic?
Because I was having patients that were on my couch that were saying that they weren't being seen and getting the advice from their GP, and there was a gap in the market. And yes, I wanted to give my patients a service, but I mean, we work to earn money as well. It's all, I'm going to be honest, aren't we? So yes, that was the way forward. And this was before the time where you kind of had to, I've now just gone CQC now with mine. So in terms of just, they had the approval come through. So yeah, that's, but yeah,
Congratulations.
well, let's say in terms of, yeah, so for me, it was, when they're in a GP appointment, they get 10 minutes, or if they're really lucky and they get a double appointment, that's 20 minutes. My consultations are an hour long. And actually, the first 10 to 15 minutes often results in the patient crying, because it's the first time that anybody is listening to them, is recognizing their symptoms and validating how they feel, because actually they feel that they're getting no validation from the other clinicians that they see. And it's no kind of negativity towards the clinicians. It's because they're so strapped for time. It's just the system isn't cut out for it.
Again, sort of listening to you there. So just so I paint it clearly for our listeners, the patients you're seeing are patients that could very well go to the GP normally for these treatments, because these services and treatments are available on the NHS. But as we all know, the system is stretched massively and the doctors are busy. And like you said, I think that's interesting then, because you're spending an hour with each of your patients, and the first 15 minutes is sort of, they're sort of breaking down, which I presume is an important part of the session, I mean, the consultation. But they only get 10 minutes, if that, with a GP. So is that why you think there's a massive move? And have you seen a huge market in sort of people going private for HRT treatments?
Yeah. Also, what you've got is the NICE guidance only allows them to be prescribing HRT from 45 onwards. So there's a cohort of patients that are in the 40 to 45 age bracket who are falling through the net, because the GP is saying you're too young to be in the perimenopause. You're too young to be going through the menopause transition. And they're saying, well, no, actually, I know what the symptoms are. This is what I'm feeling and I need the support. And I guess I'm going to take it one step back. So the average age of the menopause is 51. Your perimenopause can last for 7 to 10 years before that. So you take that back 10 years, that's 41. So you can be seeing patients that are starting with these symptoms in their early 40s. You take it another step, and actually people of South Asian origin, or if you're of Black ethnic origin, your menopause is going to be earlier. So it's going to be 48 and 49 respectively. So if you think actually at 48 and 10 years before that, that's 38, you're going to be seeing patients in their late 30s, early 40s that are going to be experiencing these symptoms. And actually at the GP practice, and the computer's going to say no. Computer says no is basically what it's going to be saying, because you're not 45. And that's not because you can't treat them. It's actually because there has to be a cutoff at some point. There has to be some sort of control, doesn't there, in terms of where the spending has to be. But what you also need to do is that make sure that if you're looking after patients in those really early years, so under the age of 40, and their periods are stopping, so they've had the menopause under the age of 40, they're a real special cohort of individuals. So they've got primary ovarian insufficiency. That's basically the ovaries have shut down. They're no longer working, but they have got huge long-term impact on care. So estrogen, obviously, we know is cardioprotective. So we need to make sure that we're looking after their heart health. We know that it helps with in osteocare as well. So we need to make sure that their bones are looked after, the psychological impact as well. And actually, if they've not completed their family, that's a huge impact in terms of the relationship that it can have as well. So you can see that if you're looking after those patients, you've got to offer some great care. And then obviously, if it's patients that are in their 40 to 45 age bracket as well, again, some of those symptoms that we've spoken about in terms of those POI patients might still be the same. But actually, if they're in the perimenopause, so that's basically they're still having regular periods to some degree for some patients. They're just starting with some of these other symptoms of kind of brain fog, forgetfulness, fatigue, loss of confidence, loss of the libido. These are all kind of things that can come up in those early parts of that perimenopause. There's a gap in the market, isn't there, in terms of where you can deliver care as pharmacists.
There's a CPP training for this, is that correct? I think you mentioned earlier, and you worked
Yeah.
with CPP and some training.
So there is some CPP module. I think that's a great way to start. It's to kickstart it, and then you can come to the allied health care training for the menopause care. That's a cheeky plug there.
Say that a bit louder. You can come to the
Allied health care training, menopause training, and you get a whole day of me talking about women's health. So I don't know if that's want you to come or want you to not want you.
And how could our listeners get access to that training? Is it just going on the Allied Health website?
Yeah, so I can share that link with you, Solomon, and we can take it from there. Yeah, they can
Fair
go
enough.
on.
Drop that in the comment section. And then anybody sort of interested, I can pick that up from that section, from the comment section. Thank you for that, Bushra. Next question says, as a pharmacist starting out, is it worth setting up private menopause service as a side hustle? What do I need to consider? I think you sort of answer the first part of it. I presume it is worth doing it. And from what you're describing, maybe not necessarily a side hustle. There is enough demand for it. What do they need to consider when setting it up?
So I would say that one, you need to make sure that you feel confident in what you're doing. I would say when I first started in menopause care, I had that Dunning-Kruger syndrome. So you do a course and you say, right, I'm going to take up the world. I can sort all these menopausal patients out in the blink of an eye. And actually, the more I learn, the less I know now. So there's very much that. So I would say get yourself onto a course and do lots of reading. Menopause isn't just like I said to you, we're quite prescriptive in terms of how we work as pharmacists. We want to know what algorithm we need to follow, where we plug these patients. But actually with menopause, it's slightly different. You can get some gray areas. So I would say upskill yourself with some of this training. There's some free training around. So you've got the CPP stuff. That's a great way to start. There's lots of other training that, you might want to kind of dabble with. The Faculty of Sexual and Reproductive Health might be something that you might want to do, but these are quite costly. The Menopause Charity has got lots of information on there as well that you can have a look at. And so I would say start with that and see where you go. And I would then say what you need to do is look at if there's any particular type of menopause care that you want to look out for. So you might say, actually, you want to consider focus on primary ovarian insufficiency. So you really want to have a focus on those women that are going through the menopause early, so under the age of 40. Or you might want to be a generalist, and that's fine as well. So I'm still a generalist. You then need to create an inventory of people that you can signpost to. So you can feel quite isolated when you're delivering menopause care. So I would say get yourself a bit of a network. So whether it's other people that are delivering the service, just so that you can share patients, if the patient's giving you consent to be able to share their details, just to make sure that you've got a bit of a safety net in place in terms of a bit of a bit of a group a support network that you can have, that you can lean on. And I still have that support network that I lead on. And if I've had a complex patient, I will say to them, would you mind if I share them with my network? And in my networks, I have gynecologists, I have endocrinologists, I have psychotherapists, I've also got a dietitian. So these are all the kind of people that you probably want to create in terms of your network. I also have somebody who's a physiotherapist in terms of, so we know they're actually, as you kind of transition through the perimenopause and into the menopause, there's lots of joint ache, muscle aches that come into effect, this rotator cuff injury. So you might see these patients in your pharmacy actually saying, oh, actually, I've got a frozen shoulder. If there's somebody that's coming in buying ibuprofen for a frozen shoulder and they're in their mid-40s, you need to think, is this a potential menopause consultation for me? Is what you need to be thinking. In terms of, so having a whole host of, so you can see you've got to have a bit of a network in place in terms, and that takes time to build. I would say initially I would do the training. I would familiarize yourself with kind of the products that are in the boxes. If you wanted to, I would reach out to pharma. And I know historically, we used to work with pharma, we didn't used to work with pharma, you don't know where you stand. Yeah, just get the samples from them, give you lots of samples that you can use. You can show your patients what they feel like. I did some training and there was some male delegates actually, which is great. We've got male allies. We had male allies in the room and I was saying, let's put some of this estrogen on, and they were scared of what was going to happen. I was like, it's only alcohol gel. So yeah, just that kind of thing. So yeah, so get your training done. Use the free ones first. Because actually you might start dabbling with it and think, oh, this is too much for me. This is not something for me. Because that's the other thing. But if you start saying, actually, then I would start paying for some of that training that's out there. Look for somebody who's kind of probably delivering the trainings, who is actually delivering the care to patients as well. And then start building up a network and Google. I will shamelessly Google what's going on with everybody in my area and follow them. I don't have any qualms about that, to be quite honest. And reach out to them. Actually, sometimes people can be territorial, but 9 times out of 10, they're quite helpful actually. And just say to them, and if there's something that this is something you really want to do, and you think that there's a local menopause clinic, just say, would you mind if I came in and sat with you? Would you mind if I shadowed you? And it's the same way that you would do in your prescribing. When you kind of branch out and you open your scope of practice to a different clinical area, you go and shadow somebody within their practice. So you would be doing the same thing. If you're branching out into menopause care, you need to be making sure that you're doing all the same things that you would be doing if you were expanding your scope of practice in any other clinical area.
Thank you for that, Bushra. The next question is pretty straightforward. I hear people are starting menopause early. Why do you think that is?
Don't think this started. So menopause, I think this is the other word. So let's get the kind of the language right. Menopause is just one point in time when you haven't had a bleed for 12 months. So it's the retrospective diagnosis that you make. So you have 12 months without a period, and that's when you have your aha moment of saying, aha, I've now had the menopause. And so what we're probably saying, the question might be actually we're experiencing, we're probably feeling women that are saying that they're having the perimenopausal symptoms. I don't know if that might be the question. So we're getting women. So I know we've spoken about some of those symptoms and they start to experience some of those. I think we're probably seeing women being more aware of what's going on. I think what we also have to remember that there's been a seismic shift in roles for women. I think, you're at your peak in your mid 40s, between 40 and 50, you're probably at your career. You're probably raising a family. You're probably looking after elderly relatives as well. And actually, what you're now doing is you're more in tune with what's going on with your body. And that's why people are kind of seeking help to make sure that they're balancing their hormones. Historically, the average age of the menopause was about 45, and then your life expectancy was probably about 56. So you really weren't living a great deal of time. Or 51, it was probably, years before that. You weren't living a long time of having in the postmenopausal era. Now what you do is the menopause is at 51, but the average age is 83. So you can see you're spending a third of your life being without your hormones. And actually, I think we women are branching careers. So we've got different roles that we're doing. I think that's probably the changes that have happened. I don't think there's been a shift in terms of the menopause being earlier. In fact, the menopause is probably happening a little later. So from 45, it's gone to 51. But what we're finding is that there's more women being more familiar with the fact of perimenopause and what those symptoms could be. And actually, in that perimenopausal era, you could well be having regular periods. You could be having all the other symptoms, but you could still be having a regular period.
Thank you, Bushra. And are there any early onset symptoms? So we talked quite a bit after you mentioned some of the symptoms there, and we discussed about the symptoms that people wouldn't necessarily link to being perimenopausal. Are there any symptoms that specifically early onset symptoms? So what do we look out for? Or are they just symptoms of perimenopausal symptoms that are appearing at any point?
It's everybody's individual. That's the other
Yes.
thing. You can't. So again, we're back to that, aren't we, as pharmacists? Well, what am I going to look out for? What's my tick list here in terms of what I'm looking for in my patient? And it's not, it's basically, it can be anything. So there's about 48 different symptoms for the menopause, and they can vary from patient to patient. The bulk of my patients that I see in clinic tend to come in with brain fog, forgetfulness. They lose their train of thought, their confidence goes, and they feel things like spatial awareness, driving at night. These becoming problematic for them. When they go to the supermarket, they're wanting to find a parking space that's got parking slots on either side of the car. So these are the kind of things that they say, saying, actually, I've lost my confidence a little bit more. So it's more of the cognitive issues that they appear with first. They might come and say, actually, I don't know if it's the start of dementia. I'm forgetting my things really regularly. I'm losing my phone. I'm losing my car keys. I'm losing my glasses, that kind of thing. Changes in vision, that's a huge one. I know we've kind of had a shift in terms of we're all kind of working on a screen more often than we probably used to. And so people are putting that down to kind of the changes in terms of vision. But in terms of the drop in estrogen can have an impact in terms of your eyesight as well. So dry eyes, that kind of thing as well.
Yeah. Fantastic. Thank you so much for that, Bushra. And a massive thank you to the listeners that sent the questions in. We've answered your question. If you're listening to these and you have any questions at all to do with any part of pharmacy as a pharmacy owner or a student, a prospective pharmacy owner, please drop your questions in the comment section or drop us a message at _BTC podcast. What we will do is we'll find a guest that will answer your questions or we'll put it to them when we get them on. Thank you very much for that. Bushra, thank you so much for your time today. Is there anything you want to get out there? Anything you want the listeners to know? What are you up to? What's next for Bushra? Where can we find you and connect with you?
Okay, so in terms of finding me, LinkedIn is probably my social media that I am most active on, probably because my children don't have access to LinkedIn. So therefore I could post things and you try to post things about vaginal health on social media for a child that's 16 is not great, really. So therefore, you'll probably find me on LinkedIn. It's Bushra Effendi on LinkedIn. I will share my email address with you, Solomon, and people can kind of drop it. I'm more than happy to support. I think there's lots of work out there. I think there's good work that is being done, but I think there's a huge market out there for you to branch out into. And I think hormonal health in general. So not only is it just around kind of women's health, but also we know that there's the GLP-1s that are kind of out there as well at the moment. So, that's another great kind of clinical area that we can work into. And we see that there's weight gain that happens in menopause or women that are going through the perimenopause and then kind of hit menopause. So that's a real, and I don't know if you're trained by a big multiple, but I was trained by a multiple and was taught about link selling. So that's a great link sell in terms of, GLP-1s and menopause care.
Just before we finish off, Bushra, you've got two boys who mentioned it earlier, and I'm sure you must be having conversations with them in the house about menopause. You're doing all of this work with it. What does that look like, and what is it that you're trying to get your boys to understand about menopause or women's health in general, and why?
Great question, Solomon. I think it's really important that we do speak to our men and our boys about menopausal health and actually hormonal health and women's health in general, because they're going to come across women in every stage of their life, whether they're at school in terms of teachers, whether it's at friends, whether they're at university, partners, friends, work colleagues. So it's really important that we do kind of give them that understanding. And yeah, you're absolutely right. The boys are probably great advocates for menopause care already at 16 and 13. And I think I said to my 13-year-old, I says, "What do you understand about menopause care?" And he took a breath and he went, "It's puberty for adults, isn't it, mummy?" And I was like, "Actually, yeah, I'll take that if that's okay." The older one gave a slightly different explanation, but I thought, actually, do you know what? I'll go with that one because that's probably got a reading age of 13, and that's probably where we need to pitch it. And I think my 16-year-old came home one day and he's aware of things, so he picks things up. So he was like, "Mommy, we had in one of the classes today, I felt really bad for my teacher. She felt like she was really quite flustered about it. And, what I did was I just knuckled down and I got on with my work." And I was like, "Great." I says, "Well, why did you do that?" He goes, "I just thought maybe she might have been experiencing some of those symptoms that you talk about all the time." All the time, obviously. And I was like, "Oh, okay." And I said, "What did you do?" He went, "I just tried to show kindness." And I realized that, you know, I didn't need to say anything. I just went quiet because that was the best thing for that moment in time. But it's great. He does it to me as well. Sometimes, like if I'm kind of having if I'm kind of experiencing those symptoms, he'll come over and he'll say, and this is great. I didn't know where he's learnt this. He went, "Mommy, do you want a solution or do you just want me to be kind?" And actually, 9 times out of 10, we just want them to be kind. We don't want a
Yeah.
solution because we've got the answers. We're women. We've got the answers. We just want people to be kind to us. And I was like, that's brilliant.
I think that's really amazing, and I think I do agree with you. We do need to teach our boys, and I think it's really great to hear that, Bushra. Again, it's that link, isn't it? And they will come across women at some point in their lives, and in different spaces and stuff. And I think it's really important that they know how to deal with women, whether it's a teacher at school, or a friend, or whatever it may be. And I think it's really, really important that we really do that. And it's really great to see that you're sort of getting your boys geared up. And I'm sure there will be a lot more compassionate than the average boy, because mommy's always, always coaching them on menopausal symptoms and what to do. That's great to hear. Is there anything else that you sort of see in terms of family time and sort of putting it out there? Boys need to know about it. We need to get it in there. Any other things you'd like to share?
I think for me, I think being South Asian, I think it's the cultural nuances as well. And I want to break those barriers because I think we're seen, again, it's seen as a taboo. We don't talk about hormonal health. We don't talk about contraception. And actually, I do talk to my children about all of that because it's really important. I'd rather they get the facts from me than to be Googling it or hearing it from hearsay or a friend. So yeah, I would say in terms of clinicians, probably speaking to those that might be parents or looking after children or may have nephews, nieces, or anybody that kind of young ones that they talk about. So, just be kind of maybe have those conversations because they are interested in those conversations. It can be a bit, they can say, "Oh, don't talk to me about it." But I think it's rather about getting the facts to them, really, because sometimes what they're hearing from their peers might not be accurate.
Fantastic. Thank you very much, Bushra. That's fantastic. Thank you so much, Bushra. It's been lovely having a chat with you. It's been great. We've covered a lot of things. I'm sure our listeners are going to find it insightful. And I really loved, we've spoken a lot over the years. And we've worked together very, very closely. And I think it's really great to have you on here. Thank you for your time again, Bushra. It's been really, really great. Thank you.
Brilliant. Well, thanks for having me, Solomon. And I look forward to the questions that are going to come through from your listeners.
Coming up in the next episode, I'm going solo again, and I will be talking about hiring and managing staff, the lessons from my mistakes. It's practical, it's honest, and it could be a game changer for your pharmacy. So stay tuned. To everyone listening, if this episode has resonated with you, please follow the show on Spotify and subscribe on YouTube, and leave a review wherever you get your podcast. If you have anyone who could benefit from listening to this episode, please share it with them. These actions help more people discover the podcast and the stories that matter. And finally, if there's a challenge you're facing right now in your pharmacy, drop us a message at _PTC podcast, and we'll endeavor to address your questions in a future guest episode response. Until next time, remember, the best prescription for success is resilience. Thank you for listening.